Hello everybody, thank you for taking the time to watch this video today. My name is Nick Goldup. I'm the Director of Care Improvement at the MND Association. During this sort of worrying and uncertain time for everybody, we at the MND Association are receiving a lot of questions coming through to us from many of you, especially through our Connect helpline and through our regional teams, which really need some clinical and expert answers. So we've formed an expert panel to help us to answer these questions. We thought it would be really useful to broadcast some of the guidance and thoughts from the group to you today. So we're going to give this a go. We've set up the technology, and it's my hope that we can repeat this periodically, and we'll invite different guests as we progress through the weeks. So I'm joined today by three of our brilliant colleagues, who many of you will know, if not all of you will know. Firstly, Professor Amar Al-Chalabi, Professor of Neurology and Complex Disease Genetics and Director of the King's MND Care and Research Centre. We've got Chris McDermott, Professor Chris McDermott, who's Professor of Translational Neurology and a Consultant Neurologist at the Sheffield Institute of Translational Neuroscience. And Professor Martin Turner, Professor of Clinical Neurology and Neuroscience and Director of the Oxford MND Care and Research Centre. So thank you for joining us today. The questions that we've got, we've been passed on to us from you all. They're in no particular order. We're just going to try and work our way through them. They'll, of course, remain anonymous. So let's see how many we can get through in about 20 minutes. And any that we don't, we can answer next week. So, Amar, the first question is for you. So, is it still safe to take Riluzole with MND during the coronavirus outbreak?
Thank you, Nick. So it depends really how long you've been taking it. The difficulty with Riluzole is really that some people in the first 3 months or so develop a reaction either in their liver or their blood. It's very rare, but it's important that we check for that. And that's done with blood tests that are done monthly for the first 3 months and then 3 monthly for the rest of the year. So if you haven't started Riluzole yet, or you're in your first 3 months of taking it, then at the moment it'll be difficult for your GP to take your blood, probably, not definitely, but probably, in which either to not start taking it for the time being or to stop taking it if you're already taking it. If you're outside that first 3 months window, then we don't know how long this lockdown will last, but your bloods would be being taken every 3 months or so anyway. And so you could probably carry on taking it for the time being. But if you wanted to stop it, that would be fine to do so for the time being. If you've been on it for more than a year, then your blood tests will be known to be stable. Otherwise, you wouldn't be on it for the whole year. And so you could carry on taking it safely.
Martin, does the use of non-invasive ventilation increase the risk of spreading coronavirus?
So using NIV does create a sort of increase in the droplets in the atmosphere. And so there is a concern if someone has an established infection, it risks infecting the people who care for them around them. And I think sensible precautions are to try and limit the use of NIV to ideally one room, but as few rooms as possible. If someone has a confirmed infection, if they don't have an infection, it's fine. And then generally carers will be taking sensible precautions. If they're coming in externally, they'll be using appropriate protection. And obviously family members are thinking about if they are going out and they've got symptoms, then they're not doing that anymore. And just being aware really that they may be at risk if the person with MND has the infection. So it's a sort of it's a practical issue, but you know, we also need to think about simple things like coughing and avoiding doing that, as well as more sophisticated things like the NIV.
Thank you, Martin. And Chris, just following on from that, really, are there any extra hygiene measures that people living with MND can take during the coronavirus outbreak?
I think, as Martin said, the most important thing is sensible precautions regarding hygiene. So those with motor neuron disease who are more vulnerable, so those in particular who have respiratory problems, may want to isolate themselves. And then when people are interacting with them, make sure that, you know, as much of the recommended hygiene measures are taken. So paying particular attention to the hand washing for carers who are coming in and when the carers leave, and with anything that's being brought in, to the household, sort of wiping it down and just being sensible, really.
Thank you. This next question is quite a large question, so I'll open up to all of you. But if we can probably ask you to answer it first. What are your thoughts regarding the impact that the COVID crisis is having on the provision of care for people living with MND?
I think you're right. It's a big question. The main issue is that people can't come into clinic anymore. So all the clinics have to be done remotely. That's both for the safety of the person being seen, but also for their carers and also for the staff. So most centres are able to offer video or telephone consultations, but the problem then is the other aspects of care, such as physiotherapy or occupational therapy, that might need a specialist input, become more difficult at the specialist centre, but they can still be provided in the community. The difficulty with examining somebody, particularly if it's their first diagnosis, is to some extent reduced because we can do a lot of the examination actually by video. We obviously don't have the hands-on aspect, so there's some parts of the examination we can't do. But in medicine, most of the diagnosis doesn't come from examination, it comes from the story the person tells us. So from the diagnostic point of view, things would be okay to a large extent. From the investigation point of view, it'll be more difficult to get investigations done diagnostically at the moment. And for people who've already been diagnosed, ongoing care in most cases should be possible to a large extent. If someone needs some new intervention like non-invasive ventilation or a gastrostomy or something like that, that will be much more difficult to achieve in the current climate, but won't be impossible, and it'll just take a lot more logistics locally to achieve it. So I think to a large extent, just to summarize, care should be able to continue, but it'll be more difficult. But we can mitigate most of the problems of not seeing people in person.
Thank you. Martin and Chris, on that point, anything other to add from your areas that you're seeing at the moment?
Well, I think that with the increase in testing that happens over the coming month and into May, we'll start to see the establishment of clean areas in hospitals to a larger extent, and that will allow us to plan procedures such as gastrostomy or for the initiation of NIV. So, you know, I think right now it's a sort of very much an emergency mode. There's an enormous amount we can do over the phone. And talking to community teams, and we'll have new solutions for those more tricky problems over the coming month.
Thank you.
I would echo just what Martin and Amar have said. I think teams are thinking creatively about how we keep in touch with our patients using the telephones and the video consultations. I think the Motor Neuron Disease Association has been providing lots of up-to-date information to support patients, and initiatives like this where we can get information out to patients to help them understand what the COVID crisis means to them, I think is also very helpful.
Yeah.
Thank you. So we mentioned gastrostomy there. Does having a gastrostomy and then contracting COVID-19 create additional issues for people living with MND? Perhaps Martin, you can answer that.
So in general, people who have a gastrostomy will be managing that. Some of them will be doing it themselves because they have the dexterity to do that, and that's much easier. And having an infection per se doesn't create a particular issue there. If the gastrostomy is being managed by someone else, then I think if the person with the gastrostomy has an infection, then more barrier methods need to be considered than perhaps would have been normally. So simple wearing of gloves and just those sort of basic hand washing maneuvers. So overall, it doesn't really change things, and in fact, you know, it's useful to be able to keep people's nutrition up if they're feeling a bit under the weather.
Thank you. Chris, one for you now. So at what point during the virus infection is it recommended to ask for external help? So in other words, how do you know when symptoms have become high risk as opposed to just being unpleasant?
So I think that depends on where somebody is in the journey with motor neuron disease. So I think if someone is very early on, just been diagnosed, perhaps has just weak hand, for example, weak arm. I think the current advice that the government is giving about using 111, to seek information online and then seeking more urgent sort of face-to-face medical intervention if they're beginning to feel breathless, so new breathlessness, I think that advice stands. I think for someone with more advanced motor neuron disease who perhaps is already breathless, perhaps is using a non-invasive ventilation, I think if they were to develop new symptoms, worsening of the breathlessness, I think that should trigger contact with the emergency services.
Thank you. Thank you. Amar, if I'm taken into hospital with coronavirus and MND, what treatment will I be given, particularly if ventilation to assist with virus symptoms is not available to me?
So there's still a number of steps that can be taken. Most people would be assessed and then, if appropriate, given oxygen, because usually the reason people are taken into hospital is because they've developed a chest infection. So that can either be a viral chest infection or there may be a bacterial component to it. If there are bacteria there, then they'll give the person antibiotics as well. Some people who are not responding even to oxygen will be given non-invasive ventilation with oxygen. That's a different type of machine from the machine that anybody with MND with non-invasive ventilation would normally have, and it allows oxygen to be given as well. And in many cases, people will be nursed in a prone position. That means on their front or sitting up, because that allows the diaphragm to move more easily, and it also allows more of the lungs to be filled with oxygen where the blood is, and that seems to improve oxygenation generally.
Just on that point, actually, there was another question we were asked, which is upright positioning in a chair or bed helpful with severe virus symptoms such as coughing or breathlessness?
And I think the answer would be yes for that.
Yeah. Okay, thank you. So the next question for Martin, this is it's a very difficult question, this one, but so will my carer or immediate family be allowed to visit or support me if I'm taken into hospital at the moment, whether for virus symptoms or other urgent treatment? There's quite a lot of people contacting us feeling anxious about this point.
Yeah, I think we've got to meet this one, head on. It's a difficult answer, and it's no. I mean, I think certainly for April and possibly significantly into May, it won't be possible to have people visit you in hospital or even to go with you. And that will factor into people's decision making, and it will need to, for some people, they need to weigh that up. I think what we're hearing from paramedics is they're advising people to make sure they have a phone that has a good supply of data and to take their charger so that they can stay in touch with family whilst they're on the ward, and there would be no issue or difficulty with using a phone in that way. But I think people have to assume that if they're going into hospital, it will be alone.
Yeah, thank you. Chris, maybe the next one for you. How long are you likely to remain in hospital if you recover from severe virus symptoms? Is there an anticipated period of admission, or does it vary widely depending on how well each individual responds?
So I think it will vary depending on individual circumstances. I think the desire is to minimize admissions as much as possible. And so the first issue will be, can this patient be managed at home safely? And that might be with using NIV a little more. It might be, with oxygen, if oxygen is proven to be safe, as we have to be careful using oxygen in patients with MND, but it can be used safely. If patients do need to be admitted, again, they will try and quickly manage things with all the steps that Amar has mentioned in terms of antibiotics, if there's a sign that there may be bacteria also involved in the infection. And I think as soon as someone is comfortable and is moving in the right direction, I think they will want to get people out of hospital as quickly as possible. And that will be the same for patients with motor neuron disease and the same with other conditions and the previously healthy. I think there want to minimise the stay in hospital.
Thank you. Amar, so the next question I've been asked is, what treatments or remedies can be given at home for virus symptoms other than paracetamol for fever?
So I think that would be the same as for any type of cold or flu symptoms. So definitely a lot of rest and sleep as far as is possible. Nasal decongestants may well be helpful. So things like Vicks or other eucalyptus-based treatments over an inhalation of warm air. Menthol-based treatments and things for a sore throat. So all of those and remain very well hydrated, of course. All of those things seem to be helpful at home, but there's no specific other treatment. It's controversial as to whether drugs in the group called non-steroidal anti-inflammatory drugs, so that's things like Nurofen or ibuprofen, whether they should or shouldn't be given. Nobody really knows whether they should, but the current advice is to take paracetamol as the main line for lowering your temperature and making yourself feel better.
Chris, if you're recovering from coronavirus, are you automatically immune, or could you get a secondary infection?
So I think there's two slightly different issues there. So somebody who has a coronavirus infection is at risk whilst they're ill of getting secondary infections with bacteria that could be treated with antibiotics. So that's one aspect. And then I think the other thing that you're alluding to is, once you've had coronavirus, are you then immune, or can you catch coronavirus again? And I think if we want to stay on the facts is we don't know. It's not been proven yet, although one would assume that you would be immune and are unlikely to get coronavirus again. But that's yet to be proven. And there are going to be tests looking at people's immunity to coronavirus, but they've not been worked up properly yet, and they're probably not going to be available for a month or two. And once we got those tests, we'll begin to develop the evidence about what actually immunity looks like in the population. So it's, I think our gut feeling is that, yes, you probably won't get reinfected with coronavirus, but we don't know for certain yet. The evidence just isn't there.
Thank you. I think we've got time.
I just add a point on that, that, you know, one of the issues about immunity is really that even if it's only for a relatively short period of time, you allow time for the virus to disappear from the population. So that's the key thing, really. It's not necessarily everybody then has to be, it's there all the time, but nobody's catching it. You actually just create a firewall so that it disappears. Because we're used to situations annually with influenza where each year there's a new strain. And so it's going to be much more of a kind of ongoing public health issue, really. But hopefully having compressed this either into history or into a situation where it's managed on a very, very low case-by-case basis. I don't think people need to be concerned that they have to have lifelong immunity, otherwise it's going to be like this forever.
Yeah, and I would add as well, there have been no properly documented cases of reinfection. So it looks like people will probably be immune, but as Chris says, we don't really know. And there are different strains of coronavirus, but they seem to be geographically limited to a large extent. So if immunity to one strain does confer immunity as it would for influenza, then probably, but not definitely, people would be immune for some time.
Thank you. And then I think we've probably got time for one last question, which is a big one, really. There's been a lot of discussion about the government's vulnerable lists, extremely vulnerable lists. So being classed as extremely vulnerable may help with priority to access local services, we believe. But would it impact negatively on whether you get access to treatment in hospital? Maybe. Oh, yeah, or Martin, please.
Well, I'll perhaps start off, and then Amar can join in, and Chris. I mean, actually, that classification in the community of extremely vulnerable is very helpful, and you know, I've seen firsthand that is really helping with local authorities identifying people who need support and food and those sorts of deliveries. There are extremely robust processes in hospitals that have existed long before COVID, whereby, when anyone comes in a very serious condition, and that's what we'd be dealing with, whether or not someone has MND, if they're in a seriously ill state, that we always want to have a conversation with individuals about how far they would want to escalate interventions. And part of that discussion is someone very reasonably saying, well, what are the chances that intervention at that level would benefit me? Would I get back to the status that I had before I was seriously ill? And that's a very individualized thing. And we know in various states of advancement of all sorts of conditions. So those kind of discussions will still happen. If someone's very ill, they may need to happen with a family member. And that's why it's important for all of us to have discussed those sorts of things with other family, regardless of whatever situation we're in, but particularly if we have a chronic condition. I think what's starting to come into the news reports, and I think it's largely unhelpful at this stage, is what ifs about if there's limited resources. And I think that all I can say there is that no doctor operates on a simplistic kind of age basis or a simplistic you have this condition basis. We're used to having to think about limited resources with things like transplants, which we have to do on a day-to-day basis. And so it is not a new thought process or new way of thinking by doctors, and it's always done in groups. So I think people shouldn't be anxious that they're going to be labelled and then treated in a certain way, and they can feel confident that people who know them will have been involved.
Yeah, I would agree with everything Martin has said. It's important to have planned ahead. So if you can put in an advanced care directive or have at least discussed with your family what your wishes are, that's important. But no doctor works on an algorithm without thinking. It is all based on the individual's wishes and the actual circumstances that person comes in with. So those kinds of discussions would be done with the patient if possible, and if not, then with family. But ideally, if the information is available beforehand through an advanced care directive, that can help guide things as well.
No, I would agree. I would emphasise the point that Martin started with, that the vulnerable, extremely vulnerable label out in the community is about ensuring that people can access support if they're self-isolating, shielding, which has been, really beneficial, supporting people. It doesn't really translate into the hospital setting. It's not a phrase that really means anything. As has been said, the decisions about what to do are based on individual preferences, of the person affected by the condition and what their wishes are. So important to have recorded them and told those around you what you would want, and then talking to the teams, the multidisciplinary teams who are there in the emergency setting, working together to come to a joint decision about what's best.
So thank you everyone for your time today. Your support and dedication and the information you've provided today is fantastic, and everyone affected by MND is hugely appreciative, I should say, of your time and your dedication to the community. So a big thank you from me on behalf of our community. My colleagues in the care team will bring together the key points today and communicate these through our association website. So please do take a look at that. We've got a specific coronavirus page on the website. So if you go to the home page, you'll see it there. But also please do speak to our staff, either regionally or nationally, through the MND Connect helpline, which is 0808 802 6262.